Hello, everyone. I'm Proton Raman, an associate editor at the Journal of Rheumatology. I'm delighted to welcome you to this interview with the authors of a substantive article featured in the October issue of the Journal of Rheumatology. Today, I have the pleasure of speaking with Dr. Olafur Palsson and Dr. Meliha Kapetanovic on behalf of all the authors of our highlighted article, which is Prevalence and Predictors of Achieving Sustained Remission in Psoriatic Arthritis, a Swedish nationwide registry study. Thank you both so much for joining me today to discuss the findings of your impactful research. So just as a way of getting, it's our pleasure. So just as a way of getting started, can you just provide the background regarding the rationale for your study and the major results that came from it?
I can start, Olafur, if that's okay.
Yeah, sure.
The background is that I actually, as a senior rheumatologist, observed that apparently patients with psoriatic arthritis get better during the treatment with biologic drugs, but still they have some residual symptom, and not so many of them reach remission. Which means are without signs of symptom of the disease, and I wanted to just see if I'm correct, if my impression is correct, and since we have a Swedish national registry, when we when both patients and we register number of swollen and tender joints and inflammatory markers. So we had the opportunity to retrieve the data from the registry and looked at the prevalence and predictors of remission in these patients. That's the general background. And Olafur maybe can continue with the process, how we really did.
Sure. And maintaining this remission state, or a state without signs or symptoms of disease, it's set as a treatment goal, which is endorsed by both Grappa and Euler. And it's an increasingly realistic goal, but apparently not all patients achieve remission. So what we wanted to do is explore the frequency of a longer period of remission, what we call sustained period of remission, where patients are in remission for at least 6 months. And then we wanted to try to identify predictors that aid in the decision making between the patient and physician. Our results, major results, show that a considerable proportion of patients with PsA receiving various advanced DMARD therapies never even achieve remission, and approximately half of them never achieved a sustained period of remission. Fewer swollen joints at first biologic or targeted synthetic DMARD initiation, it increases the likelihood of a sustained remission. And we even had signals that men were still more likely than females to achieve sustained remission.
Oh, great. So thank you for that. So just, you had a gut instinct in terms of patients not achieving remission. Was it about what you had expected or a little bit lower, like when you looked at the results?
As I mentioned before, we were expected to get the data on some patients or some proportion of patients not achieving remission. But as Olafur said, such a great proportion of patients not receiving remission is definitely disappointing. So our conclusion is, we looked at patients treated with mostly the TNF inhibitors, and we see now that we have new treatment modalities, interleukin-17 inhibitors, interleukin-12/23 inhibitors, and these treatments are used more and more used in the treatment of psoriatic arthritis. So that's also the reason that we need to switch to those treatments because so many patients do not respond to the initial biologic treatment. So to some extent, the result were what I say, we expected that some proportion would we would see that some proportion of patients will not reach remission, but not in that at that level, I must say.
Great, thank you. And did you see a period effect in the sense that it was quite a longitudinal study, and just wondering if earlier on, when the patients had more refractory disease as they went on biologics, they were a little less likely to get remission as compared to now, when, at least in North America, we tend to often use biologics even with milder disease than what you'd see in a clinical trial. Was there an effect over time?
A very good question. It could be partly the explanation, because we have in this population, this particular population we studied, could be partly the population which has established disease, not new onset disease. I really hope that with those new mode of actions and new recommendation for the treatment of psoriatic arthritis, when biologic treatments are initiated early in the disease, this data or the percentage of patients reaching remission is higher. Don't you think so, Olafur, or what is your impression as a clinician?
Yes, I think, I mean, I started my career after having access to all these advanced medications, so I'm only familiar with how things are now. But I do get the impression that we are including people that maybe have a lower disease activity and earlier in the disease course when we are applying these medications. So I think it's going better.
Okay. One of the things I noticed just reading your article, we're very envious of the database that you have, particularly the Swedish Rheumatology Quality Register. Just for the audience, can you tell us a little bit about this incredible opportunity that you have to do research in?
Yeah, sure. So the Swedish Rheumatology Quality Register, or the SRQ, it was established nearly 30 years ago in 1996, and it's been all this time been prospectively collecting data on patients with inflammatory arthritis. And it's quite a large registry. We have over 89,000 patients registered, and they're being treated at 56 different rheumatology clinics in Sweden. The registry has an excellent coverage as it has a longitudinal information on over 14,000 patients treated for psoriatic arthritis in Sweden. And the estimated coverage is over 90% of patients with PsA who are receiving biologic or targeted synthetic DMARDs in Sweden. The use of the registry, it's firmly incorporated into routine clinical care in rheumatology clinics, and physicians are encouraged to make regular registrations.
Oh, that is fantastic. Just curious, how long does it take, or does it take extra time to fill in the data that's required, or is it just seamlessly integrated into your clinical practice?
Yes, Olafur, you can answer.
It's very well integrated. The patients have already made their own registrations before they enter the room with a physician. So you are encouraged to finish the registrations that they started. Might take extra minute or so, I think, if you want to do a proper registration, but I think it's worth it.
Oh, absolutely. Great, thank you. So just a little bit curious, with so many composite measures that are available right now, just the use of DAS28 and DAPSA over such measures, for instance, as the MDA, what was the thinking behind that?
So we did explore quite a few disease activity measurements. We would, of course, have preferred to have more measurements available than the 3 we ended up using. We did explore minimal disease activity or very low disease activity criteria, the DAPSA with its 68 joints and the clinical DAPSA, and as well as the physician global VAS on a scale from 1 to 100. But the missing data for these outcome measures, it's well over 50%, in some cases much higher. So we chose DAPSA 28, DAS28 CRP, and physician global on a Likert scale from 0 to 4, since the missing data was under 25% in these cases.
Great, thank you. So there's so much value nowadays just in terms of real world studies. One of the issues that we've had doing real world evidence studies prospectively as well, is that of missing data. I'm just wondering, how did you go about handling the missing data that you talked about, for instance, with the composite measures and other variables?
So really, there are two facets to the question of missing data in our study. Firstly, there is the missing data from the baseline covariates when we are investigating different possible predictive factors for sustained remission. And there we employed a multiple imputation procedure based on a random forest algorithm to impute the missing values. Further, there are some incomplete registrations of visits in SRQ. We sometimes saw that as single visits. We saw a single visit where the disease activity could not be calculated due to incompleteness of the registration. But no changes were made to the therapy, and the patient subsequently continued his period of sustained remission. Now, in our study, we did allow for one flare of disease activity where we would connect the two visits around the flare without breaking the period of sustained remission, as long as the medical therapy was not changed during this flare. We thus allowed each period of sustained remission to continue through one flare or through one incomplete registration if the therapy was not changed.
Okay, so it's a combination of continuing on with the therapy and then just allowing potentially one flare as a sustained remission. Would that be correct?
Yeah, you could allow one flare, or you could substitute that for an incomplete registration, where we just basically assuming that the incomplete registration is a flare.
Okay. And for those that stayed on sustained remission or achieved sustained remission, what was the median duration or the mean duration?
I'm sorry, I didn't hear the question.
So you gave us the percentage of people that received or achieved sustained remission. I was just curious, what was the median duration of that remission? Like, how long were they able to sustain the remission? Like, was it 2 years, 3 years? Like, you had a mean follow-up about 5 years? Like, did they stay in remission most of that time, or if they did achieve it?
I can't remember.
No trouble at all. I was just kind of curious. Just listening to it. It's just.
I should have it here somewhere.
No, perfect. Thanks. The other thing that kind of intrigued me is there's so much made nowadays in terms of sex differences, and the male sex was a positive predictor of sustained remission, as measured by, I think, the DAS. The DAPS and maybe the PGA, or was it the DAS 28? I can't remember. Regardless of that, why do you think the male sex was a positive predictor there? Any particular hypothesis regarding that?
Yes, that's a very interesting part of the study. I would like to highlight that part because we do really know we don't know the reason for that. Maybe it depends on these outcomes measure we used when the importance of pain is higher and maybe plays a more important role in women than in men. So as a last recommendations from 2023 says we should do more research about the sex differences and the differences in sexes regarding outcomes measures and more in deep. One of hypotheses is, of course, experience of pain and how women report their pain and how they feel. The other could be hormonal differences and something we do not understand.
Great. Okay. Thank you. And has this been seen more just in terms of you noticed in your discussion that there's not too many papers just in terms of sustained remission, but has this come out as a positive predictor of sustained remission in any of the other studies that you're aware of?
Yes, there are some other studies showing that the female has a lower risk or lower chance of reaching, lower probability of reaching sustained remission. So we need to explore that more in depth, I think.
Oh, great. Thank you for that. So just regarding the real-world study that you did, that was one of the strengths that you had mentioned in the discussion regarding your study. What do you think the advantages are of the real-world studies as compared to just getting efficacy from clinical trials?
We need this register study because many of our patients, and Olafur mentioned before, in both in the manuscript and in here in his previous studies, 2/3 of patients we meet in daily clinical praxis do not fulfill criteria for inclusion in randomized clinical trials. And we need to know what is real praxis evidence and how actually it goes for our patients we meet daily clinical praxis. So register studies are very important, and prospective ones and nationwide studies shows the result we can use in the day when we meet our patients, and to assess the real efficacy of some treatment, of the new treatments. That's the one part. The second part is the randomized clinical trials are always time limited. You do not have many studies going on for 5, 6, 7 years, which means this time period we have in these observational studies. That's the main point. Yes, also we follow up all patients regardless of their comorbidities, regardless of other diseases, and those patients are often excluded from the randomized clinical trial. So it's real life data which our colleagues rheumatologists need to assess the treatment and to know in order to take care of their patients.
Great, thank you. Just wondering, is there anything else you'd like to add that we may have overlooked just in terms of the discussion today regarding your study, and a little bit as well, just in terms of any next steps regarding what you're going to do with the results that you found?
So with this result, one of the next step is a part of my PhD project. I'm a PhD student both at Lund University and the University of Iceland. And what I'm going to do is I'm going to repeat some of the data here and see if there are any differences between the countries. There's some advantages to it. We are using the same advanced therapies here in Iceland, but there are certain differences in which therapies get picked in each case. So we're going to do a comparative study as a next step to Iceland, and hopefully see if there's a change in trends as well. The Icelandic study will extend this one by 6 years, so it gets hopefully more of the newer biologics.
That sounds exciting, and we look forward to the results from your PhD as well. So
hopefully this spring.
Yes, it's nice to get it all done, isn't it?
Yes, it will be.
So thank you both for taking the time to review the findings of your paper, Sustained Remission in Psoriatic Arthritis. So to our audience, I encourage you to read the article titled Prevalence and Predictors of Achieving Sustained Remission in Psoriatic Arthritis, a Swedish nationwide registry study. It's available on the journal's website at jroom.org and in the print edition as well. So thank you so much for joining us today. Hopefully you'll tune in again next month, October 2025, when we discuss another article of particular interest from the next edition of the Journal of Rheum. We welcome all your comments on X at jroom or via email at manuscript@jroom.com. Thank you for listening.